Hello, I'm Professor Susan Young, and I'm here to talk about why we're failing people with ADHD in the United Kingdom and what to do about it. In the UK right now, ADHD is under-identified, underdiagnosed and undertreated. Many people who seek help face prejudice, long waiting lists and patchy or unavailable services. The first key barrier to getting help for ADHD is detection. When people think of ADHD, they tend to picture a young boy who's hyperactive, restless and disruptive. The problem is that someone with more subtle, inattentive symptoms is less likely to be recognised, and this may disproportionately affect girls and women. Also, people with higher intellectual functioning often mask their difficulties. There are common problems as well that coexist with ADHD that can lead to misdiagnosis. Without addressing the underlying ADHD, these comorbidities can be difficult to treat. A second barrier can be the negative attitudes of some professionals toward ADHD. These gatekeepers sometimes even question the legitimacy of a diagnosis. I recall one doctor giving evidence at an employment tribunal who described it as a newfangled fad. For an ADHD diagnosis, symptoms must be present across 2 or more settings, and for children, this means home and school. So teachers are key gatekeepers in the process of referral. But teachers may only think of ADHD if they see classic boisterous boy behaviour. They may also think that poor parenting, the home environment or diet is to blame for that behaviour and not ADHD. The third barrier to diagnosis and also to treatment is the complex system that someone with ADHD has to navigate. They might be referred by their GP for assessment, get a diagnosis and start treatment under a specialist, and then have that treatment denied when they move back to GP care. And this might be after many years of seeking help. People living in regions without adult ADHD specialist services have the right to choose these services elsewhere. However, service commissioners may refuse to fund out-of-area treatment, leaving some people in limbo and unable to access the care and social support that they need. The transition from child to adult services often breaks down. One study found that only 1 in 5 eligible young people transitioned effectively. Now this happens at a critical point in young people's lives, a time when they have to make decisions about their future, take greater responsibility for their behaviour, and they experience challenges to their identity. So what happens to the others? Well, they're left hanging between 2 services, not knowing who to turn to. Nearly all of them disengage completely. The irony is that there is specific guidance available to achieve successful transition for young people with ADHD. Another concern is access to therapy. Medication alone is unlikely to fully address the needs of someone with ADHD. In fact, a range of therapeutic approaches may be helpful. Yet, psychological therapies for ADHD are rarely available because they're considered to be expensive or because they're in short supply. Because of these barriers, people are turning to other services and sectors to gain the support they need. This means local services are inundated with requests that they feel ill-equipped and unqualified to fulfil. Some people feel they have no option but to seek out private services. This leads to a 2-tier health service, penalising lower-income families and patients. The problem with the private sector is there's a lack of transparency around the expertise and quality of care provided. This can lead to problems when people try to return to the NHS for treatment and find that their diagnosis is not accepted. So what can be done? Well, the first thing involves training. There needs to be more education about ADHD in order to improve its recognition. It's vital that training covers the diversity of ADHD in order to pick up the more subtle presentations and shift blame away from the home environment and parenting styles. This needs to reach everyone in healthcare, education, youth and social work, the police, and those working with offenders. Indeed, around 25% of offenders have ADHD, and the vast majority of them are undiagnosed. Secondly, we need to improve service provision. There should be the same level of knowledge and specialism of ADHD within primary and secondary healthcare as for common mental health conditions. We also need to join up services. The transition from child to adult services should be smooth and clear. There needs to be support and guidance available for primary care services when they are asked to take over prescribing from secondary services. People with ADHD and their families should have better access to psychological treatment, and this will enable them to develop coping strategies to better manage symptoms of inattention, restlessness and impulsivity, improve time management and organisation, and regulate emotions and behaviour. Greater transparency and the regulation of private ADHD practices will improve consistency in diagnosis and treatment. At the heart of many of the difficulties people with ADHD face is a lack of funding. It can be difficult to convince health commissioners to see ADHD treatment as a broader investment in health, education, social services, the criminal justice system, and the economy in general. Without doubt, the growing patient voice from support groups and charities across the UK has meant that visibility of ADHD has improved among the general public. Moving forward, it's clear that we must aim to reduce the stigma associated with the diagnosis of ADHD, and we must focus on improving access to all services for children and adults affected by it.